Okay. Okay, it's pheochromocytoma. Where is the headache? I thought that both like uh, age 51 um, hypertension not controlled by lisinopril, hydrochlorothiazide, amlodipine, lots of drug. So uh, renovascular hypertension can come with uh, this. Okay, fine. Sorry. Yes, renal bruit. Yes, and and another thing I missed actually, like renovascular hypertension for men. Uh, like renovascular hypertension for men is atherosclerosis, for female is fibromuscular dysplasia, where there is episodic headache. O- Okay, okay, this is pheochromocytoma. So these patients are resistant hypertension, which is defined as hypertension that persists despite treatment with antihypertensive from three different classes. Antihypertensive are from three different classes. One being diuretic. Resistant hypertension should raise suspicion of a secondary cause. Although pheochromocytoma is a potential cause of secondary hypertension that should be considered. Pheochromocytoma should release an excess catecholamine, dopamine, epinephrine, and norepinephrine into the bloodstream, resulting in characteristics of clinical manifestation: paroxysmal hypertension, highly variable blood pressure readings is present in half of the patient and clue of the diagnosis in this patient. Are accompanying episodes of anxiety and hot flashes are accompanying features of anxiety and hot flashes despite paroxetine therapy could be manifestation of pheochromocytoma. The classic symptomatic triad is consisting of episodic headache, sweating, tachycardia is present in less than half of the patient. The initial evaluation of the pheochromocytoma involves the measurement of urine or plasma metanephrine, which are breakdown products of epinephrine and norepinephrine. Elevated metanephrine levels have high sensitivity for pheochromocytoma, therefore normal levels usually normal levels usually rule out of the disease. The specificity of elevated metanephrine level is poor. However, Therefore, elevated levels warrant additional testing in the form of abdominal CT scan or MRI and positron emission tomography to confirm the diagnosis, to confirm the presence and the location of the pheochromocytoma. Okay, okay, why it is not option E? Renal duplex imaging for renal artery stenosis, which is a potential cause of secondary hypertension. However, pheochromocytoma is better explanation of these patients' labile blood pressure reading and episodes of anxiety and sweating. So the episodic headache type of thing comes in the form of anxiety and sweating. Labile blood pressure is not common with renal artery stenosis. Hypertension. Yes. Sorry. Adrenal insufficiency. Yes. And there are one feature like it is primary or secondary, like he has hyperpigmentation. No, he is on steroid, like he is on, like he is on, he is taking hydrocortisone, which is a steroid. Sorry. Yes, he needs fludrocortisone, like the thing with a mineralocorticoid property, which will increase his pressure and which will improves his adrenal insufficiency. Okay, first I would like to discuss about the box. Okay, primary adrenal insufficiency. The etiology is autoimmune adrenalitis infection like TB and metastatic infiltration. metastatic infiltration. There may be fatigue, nausea, vomiting, salt craving, postural hypertension. The hyperpigmentation is an important part, like hyperpigmentation for primary, and in secondary there is no hyperpigmentation. And in acute adrenal crisis there may be hypotension, shock, confusion. And in lab you will get hyponatremia, hyperkalemia, and eosinophilia. Hyponatremia, hyperkalemia, eosinophilia, low morning cortisol and high ACTH. Low morning cortisol and high ACTH. Treatment: glucocorticoid, hydrocortisone or prednisolone, and mineralocorticoid, fludrocortisone. The patient likely has primary adrenal insufficiency, or low serum cortisol, abnormal ACTH stimulation test, hyperpigmentation, increased melanocyte stimulating hormone, which along with ACTH is derived from propo, pro, propiomelanocortin. The resultant loss of both glucocorticoid and mineralocorticoid. The resultant loss of both glucocorticoid and mineralocorticoid production from the adrenal gland leads to hypotension, orthostatic syncope, hyponatremia, salt craving, and hyperkalemia. The patient received appropriate treatment with hydrocortisone, which has glucocorticoid and mild mineralocorticoid activity. However, most patients with primary adrenal insufficiency and are treated with hydrocortisone alone may continue to have signs of mineralocorticoid deficiency, including hyponatremia, hyperkalemia, and orthostatic hypotension. Fludrocortisone is a synthetic mineralocorticoid alone that can be given in small dose with hydrocortisone that can be given in small dose with hydrocortisone to replace the mineralocorticoid activity. In contrast, patients with central hypothalamic or pituitary adrenal insufficiency usually have adequate mineralocorticoid activity. Aldosterone secretion is regulated by RAS and are treated with glucocorticoid alone. For primary adrenal insufficiency, we need both mineralocorticoid along with glucocorticoid. But sorry, mm, yes, yes, should be high. But if your ACTH does not give the proper picture, then you have to see the clinical manifestation. Like he has look at the hyperpigmentation. The hyperpigmentation only happens in the primary, not in secondary, not in tertiary. So yes, abnormal ACTH means not normal, not in the uh, not in the normal range. It may not, it should be in normally in primary adrenal insufficiency. It should be ACTH should be high, but it is the clean. Sometimes what happens that sometimes these markers do not increase sometimes, or the or some patients actually when we take cortisol, we have to take cortisol at morning, like at 9 a.m. cortisol level. If the patient give cortisol level at 2 p.m. or like that, then the like what can I say, the abnormality may be found in cortisol, even in the ACTH, like it has a proper timing. to take this for doing this test. If you don't do this test accordingly, you will not get the correct result. So it may be confusing, but the clinical picture in here, they are clear that there is hyperpigmentation. So how this hyperpigmentation happens? This hyperpigmentation happens due to this the increased MSH, like melanocyte stimulating hormone. So this melanocyte stimulating hormone causing this hyperpigmentation, and the hyperpigmentation is the primary sign of primary adrenal insufficiency. If you just find hyperpigmentation along with like low cortisol, hyperkalemia or hyponatremia, then you can easily pick that this is primary adrenal insufficiency, no doubt. If there is no pigmentation, and then it is confusing. Got it? Most of the question I have faced, like in primary adrenal insufficiency, it may be TB or autoimmune adrenalitis. Most of them you will find the pigmentation. Okay, I albumin is normal. PTH, okay, PTH is high, parathyroid hormone is high. Is it primary hyperthyroidism, like PTH is high, calcium is high, phosphorus is bit low? He has osteoporosis, isn't it? Okay, but so he has osteoporosis. In the first, they have said now DEXA scan reveals normal bone density. Sorry, his mother has osteoporosis. Sorry, I thought he has osteoporosis. Okay, but his age is less than 50. No, because DEXA scan is normal. So why we will give DEXA, yeah, bisphosphonate? No, you are in the right track. Whatever you choose, that's correct. Okay, why we will do parathyroidectomy? Look at the indication, his age is less than 50. So this is one indication of the parathyroidectomy. Age less than 50. His age is 40. So one indication. And another is like he has symptomatic hypercalcemia. He has hypercalcemia. Calcium level is 11.8. So it is the recommendation for yeah, parathyroidectomy. Okay, I'm reading the box first. Primary hyperparathyroidism, parathyroid adenoma, most common hyperplasia and carcinoma, and increased risk of men type 1 and 2A. Okay, asymptomatic. Look at the diagnostic finding: hypercalcemia, elevated and inappropriately normal. Look at this point. Like they make this confusion. Like what does the inappropriately normal? So normally, primary hyperthyroidism, PTH is high, calcium is high. We have found that, and elevated urinary calcium excretion. We have to remember this part, like indications of the parathyroidectomy: age less than 50, symptomatic hypercalcemia, and the complication. If this patient has osteoporosis in the DEXA scan, then we have to do parathyroidectomy along with, as far I think that we have to give the bisphosphonate. Mm, and nephrolithiasis calcinosis, CKD. If CKD GFR is less than 60, then we should do parathyroidectomy. And elevated risk of complication like calcium more than 1 milligram per day above normal, and urinary calcium excretion more than 400 milligram per day. So this patient, hypercalcemia, hypophosphatemia, and elevated PTH level consistent with primary hyperparathyroidism. PTH causes increased reabsorption of calcium from the distal tubule, but net urinary calcium excretion is increased. Net urinary calcium excretion is increased due to excess resorption of calcium from bone. By contrast, familial hypocalciuric hypercalcemia is characterized by elevated PTH but low urinary calcium excretion, less than 100. Okay, in familial, elevated PTH but low urinary calcium excretion. But in primary hyperparathyroidism, uh, urinary calcium excretion is increased. Okay. Parathyroidectomy is recommended for patients with symptomatic hypercalcemia. It is also recommended for patients such as this one with complication: osteoporosis, nephrocalcinosis, nephrolithiasis, impaired renal function, or at significant risk of complications: serum calcium more than 1 milligram per day level, normal urinary calcium excretion more than 400 milligram per 24 hour. In addition, younger patients age less than 50, such as this one, are likely to have complications during their lifetime and should be offered surgery. The patient is relatively young. The patient is relatively young and have nephrolithiasis, likely as a complication of primary hyperparathyroidism. He should therefore refer for parathyroidectomy. Parathyroid imaging like system-AV scan and ultrasonogram helps optimize the surgical approach by potentially determining the affected site and evaluating for the possibility of a minimally invasive intervention. Okay. Yes. Extended extended CT imaging would be indicated for suspected hypercalcemia of the malignancy, which typically presents with severe symptomatic hypercalcemia, low PTH, elevate low PTH and elevated PTH related protein. Imaging to evaluate for multiple endocrine neoplasia syndrome is recommended only if there is evidence of multiglandular hyperparathyroidism or additional endocrine tumors. Uh, yes, when he's peeing a lot, like more than 3 liter, what is your differential? Like more peeing is called, yes, and in polyuria there is only two differential. Like is it primary polydipsia? Like he is eating, sorry, he is drinking a lot and peeing a lot, or is it diabetes insipidus? So then what will you do? Yes, as he is drinking a lot, we will stop his water to intake. Then we will check the vitals. Then we will check the actually not vitals actually. Then we will check the multiple things. And this is the thing we need to check. Okay. I should do a water deprivation test too. Okay. Polyuria adults. Sorry. Yes. Polyuria if adults uh, uh, u- urine output if it is more than 3 liter per day, and in children if urine output is more than 2 liter per day, then you have to look, is it concentrated urine or is it dilute urine? And then you have to look, is it concentrated urine or is it dilute urine? If it is concentrated urine, that means urine osmolarity more than 600, then water deprivation test is not indicated. Assess for solute diuresis like glycosuria, like he may have diabetes mellitus, that's why these high osmolarity and these concentrated urine. And if it is dilute urine, like urine osmolarity less than 300 milliosmol per kg, this patient has 120 milliosmol per kg, so it is dilute urine osmolarity less than 300. Then you have to do serum sodium and plasma osmolarity. Serum sodium and plasma osmolarity. If serum sodium is less than 145, if serum sodium is less than 145, water deprivation test is indicated. Water deprivation test is indicated. So distinguish between the AVP disorder like arginine vasopressin disorder like diabetes insipidus versus a primary polydipsia. And if if serum sodium is more than 145, if serum sodium is more than 145 and plasma osmolarity is more than 295 milliosmol per kg, then water deprivation test is not indicated. AVP disorder confirmed, assess response to desmopressin. So if serum sodium is more than 145 and plasma osmolarity is more than 295, then we do not need to do water deprivation test. We are confirmed that it is AVP disorder, like it is diabetes insipidus. Now you have to differentiate: is it central diabetes insipidus, or is it nephrogenic diabetes insipidus? Say in central or cranial diabetes insipidus, desmopressin will work because they have ADH deficiency. Got it? Okay, I'm reading now, reading the explanation below. You got the idea? Okay. So extracellular fluid balance is regulated. Extracellular fluid balance is regulated by arginine vasopressin, also known as antidiuretic hormone. AVP is secreted from the hypothalamus. AVP is secreted from the hypothalamus and posterior pituitary in response to rising plasma osmolarity. It stimulates renal water reabsorption. Resulting in concentrated urine. Patients with AVP deficiency, formerly central diabetes insipidus, AVPD or AVPR, formerly known as nephrogenic diabetes insipidus, has impaired urinary concentration ability and produce inappropriately dilute urine. This patient has polyuria. With dilute urine osmolarity less than 300 milliosmol per kg. Urine osmolarity less than 300 milliosmol per kg, and specific gravity is less than 1.006, suggesting of ABP disorder. His serum sodium level is normal, which is common when a patient is able to drink sufficient water to replace renal losses. Water deprivation testing can distinguish between AVP disorder. Water deprivation testing can distinguish between AVP disorder and primary polydipsia. Water is uri- uh, serum osmolarity is more than 295 milliosmol per kg and serum sodium is more than 145 milli equivalent per liter, which is normally would trigger maximal AVP secretion. Urine osmolarity is then reassessed. An appropriate rise in urinary concentration more than 600 indicates primary polydipsia, and persistently dilute urine confirms ABP disorder if urine also remains dilute following administration of the desmopressin. And they are talking about the desmopressin test. You got this point. When you are confirmed, like urine osmolarity is more than 295 and serum sodium is more than 145, that means the water deprivation test is not indicated now, isn't it? So now you need to give the desmopressin. An appropriate rise in urine concentration more than 600 milliosmol after giving desmopressin indicates primary polydipsia and persistently dilute urine and AVP disorder. If urine osmolarity also remains dilute, sorry, in here, if urine osmolarity also remains dilute following administration of the desmopressin, then AVP resistance, that means nephrogenic diabetes insipidus, which in children most commonly due to hereditary disorder, is likely. The water deprivation is performed in the hospital, supervised in older children, and should not be used in very young child due to risk of severe hypernatremia. And sodium for CNS. So if there is hypo or hypernatremia, it will cause seizure. That's why they are talking about the supervised. Got it? Yes, normal. Okay, physiologic defense against hypoglycemia. Physiologic defense in hypoglycemia. If there is decreased insulin, it will decrease a peripheral glucose use and hepatic increase hepatic gluconeogenesis and hepatic glycogenolysis. Hepatic glucagon glycogenolysis and increased glucagon will cause increased hepatic gluconeogenesis and glycogenolysis. So physiological defense against hypoglycemia: decrease insulin, increase glucagon, increase epinephrine, and increase cortisol and growth hormone, which will decrease the blood glucose level. So abnormalities of the cystic fibrosis are transmembrane conductor regulator gene cause in formation of viscous mucus, which can lead to obstruction of the pancreatic duct, inflammation and fibrosis of the surrounding gland. In addition to exocrine pancreatic insufficiency, destruction of insulin secreting beta cell in the pancreatic islets can develop, resulting in pancreatogenic diabetes. In such cases, exogenous insulin is required. Pancreatogenic diabetes is common in patients with pancreatectomy. Pancreatogenic diabetes is common in patients with pancreatectomy and chronic pancreatitis of other causes. Alcohol. Patients with pancreatogenic diabetes typically also lose glucagon secreting alpha cell. Because glucagon is the primary counter-regulatory hormone to insulin, these patients are at risk of insulin-induced hypoglycemia, which may be rapid and severe loss of alpha cell reserve, in also seen in patients with long-standing Type 1 idiopathic diabetes. This patient is likely experiencing recurrent hypoglycemia due to unopposed insulin analog therapy. Due to unopposed insulin analog therapy, management requires conservative insulin regimen, and she should be advised careful monitoring of home glucose is necessary. In addition, she should be issued an emergency glucagon kit for use in severe hypoglycemia. Got it? He has diabetes, and this is acanthosis nigricans, isn't it? Acanthosis nigricans, the type 1. Because age is only 16. Anti Type 1 is absent insulin, and type is it maybe antibodies. Absent insulin is insulin deficiency is type 1, and insulin resistance with relative type 2. Yes, there. This is type 2 because acanthosis nigricans. This feature is associated with type 2. I don't know yet. Also, I gave the same wrong answer. I don't know that these acanthosis nigricans is specific for type 2, and type 1 is associated with like thyroiditis and celiac disease, autoimmune disorder. Okay, first the box. Because in type 1 there is insulin deficiency, and type 2 is insulin resistance with relative insulin deficiency. Insulin resistance with relative insulin deficiency. Yeah, epidemiology type 1 children. Oh, sorry, epidemiology not important. Look at the presentation. Presentation in type 1 there may be polyuria, polydipsia, weight loss, and ketoacidosis is common. This patient has no ketoacidosis, no ketone body present. This one is the important factor we missed. So in type 2, ketoacidosis is uncommon, usually asymptomatic and insidious. Associated conditions, autoimmune disorder like thyroiditis and celiac disease. And for type 2, dyslipidemia, hypertension, and acanthosis nigricans. C-peptide is low for type 1, and C-peptide is elevated in type 2, and autoantibodies usually absent in type 2 but present in type 1. Yes. Okay, now This patient has symptomatic hyperglycemia, polydipsia, and elevated hemoglobin A1C consistent with diabetes mellitus. Although these patients most commonly have type 1 diabetes mellitus, the incidence of type 2 diabetes mellitus in older adolescent is increasing with the rise in children obesity, BMI more than 95, these patients age, BMI, family history of diabetes mellitus, acanthosis nigricans make type 2 diabetes mellitus most likely diagnosis. Or pathogenesis involves environmental and genetic factor. Excess adiposity contributes to insulin resistance in adolescent. This resistance is potentiated by rising growth of hormone during puberty. Pancreatic beta cell initially produce more insulin to compensate, but become dysfunctional over time or produce less insulin, resulting in hyperglycemia. Insulin resistance alone does not always correlate with the development of the diabetes, and the genetic factors likely also play a role in impaired insulin secretion in susceptible individuals. Finding associated with insulin resistance include central obesity, hypertension, dyslipidemia, acanthosis nigricans is common, possibly reflecting insulin effects on the keratinocyte and the fibroblast. manifests as velvety hyperpigmented patches in the intertriginous area, neck, axilla. Present patients are at increased risk for candidiasis as seen in these adolescents because hyperglycemia allows increased adhesion of candida. Hyperglycemia allows increased adhesion of the candida to the epithelium. Okay, yes. Anti-insulin receptor antibody may cause severe insulin resistance by blocking the action of the insulin. This condition is exceedingly rare. Anti-insulin receptor antibodies is exceedingly rare, often coexist with other autoimmune disorders like SLE, making far likely than type 2 diabetes mellitus in this patient. Okay, okay. Can you give me 5 minutes? I'm coming. Okay. Hello? Yes. Okay. Okay, it is diabetic foot ulcer. Neuropathic ulcer. Neuropathic ulcers are caused by repeated pressure, frictions, or trauma due to lack of sensation in the local tissue. They typically occur in the weight bearing. They typically occur in the weight bearing side, head of the first metatarsal on head of the first metatarsal on the sole of the foot. The location of these patients' ulcer and the lack of association of pain is consistent with neuropathic ulcer. Diabetes mellitus is the common cause of diabetes mellitus is the common cause of neuropathic ulcer, whereas neuropathy involving small nerve fibers typically causes pain and paresthesia. Involvement of large fibers produces sensory loss that can allow minor injuries to go unrecognized until the development of an ulcer. Associated autonomic dysregulation can lead to decreased sweating and skin fissuring, and further increases risk for ulceration. In addition to the ulcer, this patient has other risk factors for diabetes, obesity, hypertension, peripheral neuropathy can present at the time of type 2 diabetes mellitus diagnosis in the same patient and can occur be asymptomatic. He should therefore screen for diabetes with a hemoglobin A1C or fasting glucose measurement. The ankle bra- fasting glucose measurement. ABPI for peripheral artery disease. Look at the arterial ulcer, toe gangrene. Arterial ulcer usually in the tip of the digits, and it is cool, pale skin, dermal atrophy, diminished pulse. So arterial ulcer, diminished pulse, tip of the toe. And the venous ulcer for duplex venous ulcer. When I see the ulcer, I feel all the same. Okay. Sometimes it is very hard to differentiate. Like diabetes ulcer, patient has a history of diabetes and the ulcer is in the food, then it can be accessible. But the arterial and venous are very tough, as for me. In venous ulcer, they have intake pulse, isn't it? Medial malleolus, yes. Usually in the medial malleolus, yes. And arterial ulcer in the tip of the toes. Tip of the toe. Okay. Okay. Very high, low, yes. E hypothyroidism, neonatal hypothyroidism. Yes. Okay. Congenital hypothyroidism pathophysiology is thyroid dysgenesis. Most common like agenesis, hypoplasia, or ectopy. Clinical manifestation asymptomatic at birth. Asymptomatic at birth can rarely present with delayed passage of meconium. Asymptomatic at birth. Symptomatic weeks to months after birth. Symptomatic weeks to months after birth as maternal T4 wanes. Hypometabolism, decreased heart rate and temperature, lethargy, poor feeding, hypotonia, constipation, jaundice, mucopolysaccharide accumulation, macroglossia, umbilical hernia, and delayed bone maturation. Elevated frontally, newborn screening. A diagnosis is newborn screening, TSH high, T4 low, and treatment is levothyroxine. Prognosis no deficit if treatment is started in neonatal period, no deficits if treatment started in neonatal period. Untreated disease leads to intellectual disability, developmental delay, and poor growth. So this patient, this 1 month old infant has clinical features and lab results: increased TSH and decreased T4 consistent with congenital hypothyroidism. The most common cause of this condition is thyroid dysgenesis, agenesis, hypoplasia, ectopy. During early gestation, the thyroid diverticulum forms in the primitive pharynx and descends to the anterior neck, remaining attached to the tongue by the thyroglossal duct. Any disruption in the process can cause thyroid dysgenesis, leading to impaired thyroid hormone synthesis. Most patients with congenital hypothyroidism are identified via neonatal screening while asymptomatic. Those who are not screened at birth, those who are not screened at birth, as may have occurred in infant who was born at home, are diagnosed after developing symptoms, typically weeks to months after the birth due to waning of maternal derived T4. Generalized hypometabolism leads to poor feeding. Generalized hypometabolism leads to poor feeding, um, and decreased activity and prolonged jaundice, more than 2 weeks of jaundice, which is due to decreased GI motility and diminished activity of the hepatic enzyme involved in bilirubin metabolism. Other findings are due to mucopolysaccharide accumulation in soft tissue and increased large protruding tongue and a hoarse cry, laryngeal involvement as seen in this patient. Okay. Okay. Chronic hyperglycemia in diabetes is linked to increased mortality and morbidity from microvascular retinopathy, nephropathy, and macrovascular cardiovascular disease complications. However, use of pharmaceutical intervention to achieve glycemic control appears to have mixed effects. on reduction of mortality and macrovascular complication. Major randomized controlled trials, UK prospective diabetic, United Kingdom prospective diabetes study, and action to control cardiovascular risk in diabetes suggest intense glycemic control HbA1c in between 6 and 7 with insulin and sulfonylurea significantly improves microvascular endpoints such as retinopathy and nephropathy. In contrast, these trials suggest that intensive glycemic control does not reduce macrovascular complications, stroke, MI, or all-cause mortality. Strict glycemic control with insulin is also associated with significantly increased risk of hypoglycemia. Furthermore, Accord trial showed that very intensive glycemic targets A1C between 6 and 6.6 and 6.5 appear to increase risk of all cause and cardiac mortality. Given the established benefit of glycemic control on the risk of microvascular complication and the potential risk of over, overly strict glycemic control, the recommended target of HbA1c for most non-elderly patients is 7. In addition, efforts to reduce the risk of macrovascular complication should also include careful management of other lifestyle and cardiac risk factors, smoking, blood pressure, lipid. Okay. Show with a palpable mass, yes. Without a mass, yes. What we will find in that? Cancer. Yes, should should be, but testosterone, dihydroepiandrosterone, both are normal. Yes, beta HCG is, I think the testicular thing is that. Okay, because breast mass cannot increase beta HCG. Okay, so evaluation of the gynecomastia, enlargement of breast tissue in male patient, enlargement of breast tissue in a male patient, discrete enlargement of glandular breast tissue, discrete enlargement of glandular breast tissue, rule out toxic exposure, herbal supplement, anabolic steroid cannabinoids, measure HCG, LH, testosterone, and estrogen. If HCG is high, think about testicular or gonadal germ cell tumor. If LH and testosterone is low or normal, if LH or testosterone is low, it is central hypogonadism like pituitary tumor. If LH is high but low testosterone, it is primary hypogonadism. In primary hypogonadism, testosterone is low but LH is high, Klinefelter. If both are high, LH is high, testosterone is high, then possible thyrotoxicosis. If estradiol is high, it is testicular or adrenal tumor. So beta ECG is high for testicular or gonadal germ cell tumor, and estradiol is high for testicular and adrenal tumor. Okay, gynecomastia is an abnormal growth of the breast tissue in male patients. It generally results from an increased ratio of estrogen, which cause hyperplasia of the breast ductal epithelium, and fibrosis of the stromal cell to androgen, which inhibit breast development. Although estrogen-induced gynecomastia is typically bilateral, unilateral findings are also common, and breast may enlarge more rapidly than the other. One breast may enlarge more rapidly than the other. Besides rapidly progressive gynecomastia, this patient has a low to normal this patient has a low to normal testosterone level, elevated estradiol, and striking rise of beta ECG, which most commonly represent HCG secreting germ cell tumor of the testis. Excess secretion of beta ECG by testicular germ cell tumor suppresses testosterone production in the Leydig cell and increases aromatase activity and conversion of androgen to estrogen. The resulting increase in estrogen-androgen ratio can cause gynecomastia. Even though this patient has a normal testicular examination, ultrasound is indicated to exclude an occult mass. Next. Yes. Okay, this is postpartum thyroiditis. This patient has postpartum thyroiditis, an autoimmune disorder similar to painless thyroiditis, but is defined as occurring less than 12 months after childbirth. Postpartum thyroiditis is characterized by lymphocytic infiltration on the thyroid gland with disruption of the thyroid follicle and release of preformed thyroid hormone. There may be elevated thyroid hormone T4, T3, suppressed TSH level, and positive TPO and negative thyrotropin. Positive TPO marker for autoimmune thyroid disease that is commonly associated with Hashimoto, and negative for Graves. Radioiodine uptake is low. Okay. Radioiodine uptake is low because thyroid metabolic activity is suppressed. However, radioiodine uptake testing is not always needed for diagnosis and is frequently deferred in patients who are breastfeeding. Uh, Postpartum thyroiditis is self-limited and specific antithyroid treatment is not recommended. This is important, not recommended. Beta blocker propanolol should be prescribed to attenuate hyperadrenergic symptoms. Patients should be monitored with serial lab tests because transient hypothyroid phase may occur due to thyroid hormone depletion. Testing should continue until patient returns to euthyroid state. Okay, yes. Okay, postpartum thyroiditis. Confirmed diagnosis by T3, T4 is high and low TSH, um, increased thyroglobulin, decreased radioiodine uptake, and positive TPO and negative TRAB. If hyperthyroid phase like T3, T4 high, TSH is low, beta blocker for symptom control. If hypothyroid phase like T3, T4 is low, TSH is high, breastfeeding or attempting pregnancy, hypothyroid symptoms, and TSH more high more than 6 months. If hypothyroid phase and breastfeeding or attempting pregnancy, this patient is not breastfeeding. Patient is breastfeeding and wants to continue. So why it is not? Uh, Sorry, as the this patient is breastfeeding. Okay, it is not hypothyroid phase. Okay, that's why levothyroxine is not the answer. Okay, breastfeeding or attempting pregnancy or hypothyroid symptom and TSH is high more than 6 months, then levothyroxine. If it is euthyroid state, normal everything, wean off levothyroxine as tolerate and annual TSH measurement. Okay. Yes. What is your diagnosis? Yes. And there is hyperpigmentation. And another thing, in primary adrenal insufficiency, eosinophil count is higher. Sometimes a peripheral eosinophilia. Okay. So these patients have primary adrenal insufficiency, also known as Addison's disease, which commonly results from autoimmune process against bilateral adrenal cortex. It often occurs in conjunction with autoimmune disease, primary hypogonadism, vitiligo. The clinical manifestation of primary adrenal insufficiency result from deficiency of hormone production, a deficiency of hormone production in all three layers of the adrenal cortex, reduced mineralocorticoid, mainly aldosterone production, leads to renal sodium wasting and consequent hypovolemia and weight loss, hypotension and orthostasis. Reduced glucocorticoid Reduced glucocorticoid cortisol production causes fatigue and contributes to hypotension. There is also decreased negative feedback on ACTH. There is also negative feedback on ACTH, which leads to high level of both ACTH and its precursor, propiomelanocortin, the cause of hyperpigmentation of the skin and mucous membrane due to increased levels of melanocyte stimulating hormone, which is also derived from POMC, propiomelanocortin. A peripheral eosinophilia is common and likely due to reduced migration of the eosinophil from the bloodstream into the tissue in the setting of low cortisol. For unclear reasons, abdominal pain, tenderness, and normocytic anemia are often present as well. Reduced production of adrenal androgen dehydroepiandrosterone can lead to decreased libido, secondary sexual characteristics, pubic hair. These effects are typically only seen in women because of testicular androgen production continues in men. Next, calcium is low, phosphorus is high. PTH, is there any PTH? Hypocalcemia, hypophosphatemia. Is it hyperphosphatemia and hypocalcemia? It's not CKD. Is it primary hypothyroid, hypoparathyroidism in primary? Sorry, because primary hypoparathyroidism, PTH is low, calcium is low, phosphate is high. If we think in a general way, okay. So I haven't read anything. I am just trying to fix the calcium and the phosphorus and the PTH. So yes, I have picked. Okay. Okay, this patient clinical features and lab findings are consistent with hypocalcemia caused by autoimmune primary hypoparathyroidism. In endocrinology, everything is autoimmune. In primary adrenal insufficiency, number one cause is autoimmune adrenalitis. In here, autoimmune primary hypoparathyroidism. Okay. Symptoms of hypocalcemia usually stem from neuromuscular irritability and manifest as perioral tingling and numbness, muscle cramp, tetany, carpopedal spasm, and seizures. Prolongation of the QT interval can also occur if the hypoglycemia develops rapidly if the hypocalcemia develops rapidly, as in surgical patients, the symptoms are typically more severe. The symptoms are typically more severe even with modestly reduced serum calcium level. However, chronic hypocalcemia may be asymptomatic even with markedly reduced serum calcium level. The cause of primary hypoparathyroidism include post-surgical, most common cause autoimmune, congenital absence or mal congenital absence or maldevelopment of parathyroid glands, DiGeorge syndrome, defective calcium sensing receptor on the parathyroid gland, and not non-autoimmune destruction of the parathyroid gland due to infiltrative disease such as hemochromatosis, Wilson disease, and neck irradiation. Post-surgical hypoparathyroidism can occur during thyroidectomy and subtotal parathyroidectomy, removal of three-half of the parathyroid gland for parathyroid hyperplasia. Autoimmune hypoparathyroidism is the most common non-surgical syndrome. Okay, it's Sheehan syndrome. Okay, in Sheehan syndrome, pathogenesis is obstetric hemorrhage caused by hypotension, and postpartum anteropituitary infarction. Clinical feature is spectrum of disease based on the severity of pituitary function, immediate adrenal crisis years after delivery, lactational failure due to low prolactin, amenorrhea, hot flushes, vaginal atrophy due to decreased FSH and LH, fatigue, bradycardia due to low TSH, anorexia, weight loss, hypertension due to low ACTH, and lean body mass due to decreased growth hormone. Diagnosis is diagnosis cortisol level, thyroxine level, FSH level, and prolactin level. And treatment is corticosteroid and estrogen progestin replacement. Estrogen progestin replacement therapy. So these patients fatigue, lactational failure, amenorrhea, most likely has pituitary insufficiency resulting from pituitary infarction. The pituitary gland is enlarged during pregnancy. However, because its supply It does not increase proportionally. And perfusion is by low pressure venous portal system. And the anterior pituitary is particularly susceptible to hypotension related ischemia. In contrast to the pituitary gland, has a direct arterial supply and is not susceptible. Therefore, the classic presentation of postpartum pituitary infarction Sheehan syndrome occurs after a massive PPH. The constellation of the symptoms in Sheehan syndrome occurs due to deficiencies in the following anteropituitary gland hormones: ACTH, which causes decreased cortisol level resulting in fatigue, hypotension, anorexia, loss of secondary body hair, secondary adrenal insufficiency; prolactin, which cause lactational failure; FSH and LH, which causes decreased estrogen production, resulting in amenorrhea, vulvovaginal atrophy, dyspareunia, decreased libido; TSH, which causes decreased T3 and T4, resulting in fatigue and bradycardia; and the growth hormone, which decreases the lean body mass in adults. The diagnosis is typically blood hormone level, particularly a serum cortisol level, because this test has most diagnostic accuracy, and this test has more diagnostic accuracy, and cortisol deficiency is the most life-threatening complications. Treatment involves hormone replacement. Okay. Like pituitary hemorrhage, empty empty Shella syndrome, empty Shella. Uh, Yes, seizure and eczema. The patient did not undergo prenatal screening, but the anterior fontanelle is open, and there are no dysmorphic features. Syphilis may come with dysmorphic feature. It's not TSH, isn't it? Is it phenylalanine? Like, okay. I haven't seen your answer, but when TSH is ruled out, then I go for phenylketonuria because this one is must for uh, this one is the routine test for a baby in US actually. Okay, so phenylketonuria. This patient has new onset seizure, which is commonly due to infectious, structural, or metabolic causes. This patient is afebrile with normal complete blood count and brain imaging, making an infectious or structural cause unlikely. A transiently disrupted metabolic process, hypoglycemia and hyponatremia, is also unlikely given the normal electrolyte and glucose. However, the microcephaly, head circumference at second percentile, and lack of newborn screening raise concern for inborn error of metabolism, such as phenylketonuria. So PKU, phenylketonuria, is a rare autosomal recessive disorder in which phenylalanine hydroxylase deficiency results in inability to metabolize phenylalanine into tyrosine. Although small amounts of phenylalanine are necessary for growth and the development, excess phenylalanine is thought to disrupt normal neuronal development and increase oxidative stress in the brain, causing irreversible neurologic injury when untreated. Neurologic findings include microcephaly, seizure, and poor feeding. Other features include eczema, as seen in this patient, hypopigmentation, and a musty odor. Patients with PKU are asymptomatic at birth and usually identified as hyperphenylalaninemia, uh, that is on tandem mass spectrometry, on universal newborn screening, which tests more than 20 disorder, metabolic disorder, HIV, cystic fibrosis, prompt initiation of phenylalanine restricted diet, avoiding protein rich food, prevents disease manifestation in undiagnosed or untreated patient like this girl. Serum phenylalanine and neurotoxic byproducts accumulate over weeks to months when dietary phenylalanine breast milk formula is introduced. Diagnosis is symptomatic. Patients is typically established via hyperphenylalaninemia on serum amino acid analysis. Okay. Yes. Yes. Flow cytometry for lymphocyte subset can be used to diagnose severe combined immunodeficiency disease, which can cause neurologic finding due to CNS function. However, this patient is afebrile and easily arousable and has a flat frontal, making infection unlikely. Moreover, patients with SCID typically have lymphopenia and poor growth in height and weight, findings not seen in this girl. And the C, rapid plasma reagent testing screens for congenital syphilis. Symptomatic patients typically have hepatomegaly and macropapillary rash. Neither is seen in these girls, although CNS involvement can rarely occur. Rapidly increasing head circumference with bulging frontally would be expected. And patients with congenital hypothyroidism normally diagnosed via newborn screening may develop lethargy, poor feeding if untreated, but seizures would not be seen. Other expected findings include white frontally and macroglossia. Got it? Larson. Okay, sorry for that long. Okay, surgical resection. Surgical resection is the primary treatment for papillary thyroid cancer. The extent the extent of the surgery depends on the tumor size, extrathyroidal invasions, extrathyroidal invasion, patient age, lymph node involvement. Small tumors less than 1 centimeter without evidence of lymph node involvement, or contralateral thyroid abnormalities can usually be managed with partial thyroidectomy or lobectomy, whereas large tumors usually warrant total thyroidectomy. In addition, regional lymph node or central compartment lymph node dissection is usually performed for a papillary cancer with lymph node metastasis or extrathyroidal invasion. For surgery, Adjuvant therapy with radioiodine ablation is warranted for patients with increased risk of tumor recurrence, extrathyroidal invasion, lymph node metastasis, and incomplete resection. TSH TSH can stimulate growth of occult residual or metastatic disease. For this reason, patients at increased risk of recurrence should also receive adequate doses of thyroid replacement to suppress TSH secretion. Okay. He has carpal tunnel syndrome. Acromegaly. Okay. So clinical suspicion for acromegaly. We'll do clinical suspicion for acromegaly. We'll do insulin-like growth factor level 1, IGF-1 level. If it is normal, then it rules out the acromegaly. If it is elevated, and then if IGF-1 level is elevated, then go for OGTT, oral glucose suppression test. Oral glucose suppression test. If oral glucose suppression test adequate growth hormone suppression rules out acromegaly. Inadequate growth hormone suppression, then we will do MRI of the brain. If MRI of the brain show pituitary mass, then surgical versus medical management. If it is normal pituitary, if MRI of the brain shows normal pituitary, uh, normal pituitary, evaluate for extrapituitary cause of acromegaly like ectopic growth hormone and growth hormone secreting tumor. Okay. Okay, sorry. Okay, this patient's presentation, this patient presentation, coarse facial features, arthalgia, uncontrolled hypertension, enlargement of the digit, carpal tunnel syndrome is consistent with acromegaly. This condition is caused by excess growth hormone secretion, usually due to pituitary somatotropic adenoma. Other common features include jaw malocclusion, hyperhidrosis, cardiomyopathy, macroglossia, pituitary mass effect symptoms, headache, visual field defect. Growth hormone stimulates Insulin-like growth factor 1 secretion, which mediates most of the clinical manifestations of acromegaly. IGF level in patients with acromegaly are consistently elevated throughout the day and are useful as initial test, in contrast to growth hormone, which fluctuates widely and has low sensitivity and specificity. Treatment can alleviate many of the physiologic effects hyperglycemia, uh, mm, physiologic effects of acromegaly, although skeletal and joint abnormalities are largely reversible. Initial treatment for most patients include transphenyral resection of the pituitary adenoma. For patients with residual or unresectable tumor, medical therapy is indicated. Options include somatostatin analog, octreotide, or growth hormone receptor antagonist, pegvisomant. Okay. Yes. In normal individuals, administration of the glucose suppresses the growth hormone secretion, whereas in patients with acromegaly, growth hormone is not suppressed and may paradoxically increase. Measurement of growth hormone. Measurement of growth hormone in an oral glucose suppression test to confirm the diagnosis of the acromegaly. This test is especially useful in patients with equivocal IGF-1 level, is it is not recommended as initial diagnostic test. And once acromegaly is confirmed, patients should undergo MRI of the head to identify the pituitary mass. However, incidental pituitary lesions are common in normal patients and can be misleading. As a general rule in endocrinology, imaging is performed after biochemical diagnosis of a disorder is made. Okay. BMI is anorexia. Is he has anorexia nervosa? Sorry, swelling in the knee. Maybe I don't know. I am just making you confused. Hyperkalemia, if there is destruction of bone, destruction of muscle, then it can cause hyperkalemia. So, okay, hypotension, hy yes, maybe. Why it is increased TSH? Increased TSH means like a low thyroid, hypothyroidism. He hasn't weight gain or he has weight loss. No, M maybe you're A1. No, no, we are right because we diagnose right, but we give the answer wrong. Okay, I am reading the explanation. So decrease bone mineral density. Mm, These patients low BMI and these patients low BMI and distorted body image are suggestive of anorexia nervosa, weight loss and chronic malnutrition. Weight loss and chronic malnutrition leads to dysfunction in multiple organ systems. These patients' clinical presentation of dry skin causing scratching and excoriation, edema, abdominal distension, hyperactive bowel sound, and vital sign abnormalities, hypertension, bradycardia, is consistent with medical complication due to anorexia nervosa. Gastroparesis, abdominal bloating are common. Edema is due to electrolyte and electrolyte edema is caused by electrolyte and fluid disturbance is commonly seen in ankles and around the eyes. Seen in the ankles and around the eyes. And decreased bone mineral density due to combination of the factor including various endocrine abnormalities, hypercortisolism, growth hormone resistance that results in increased bone fracture. Other complications include hypercarotenemia, altered metabolism of the cholesterol leading to hypercholesterolemia, cardiac atrophy, arrhythmia, amnesia, lanugo, and seizure may happen. Okay, where is the? Okay, I'm reading the box. So, decrease bone mineral density. Okay, diagnostic criteria significantly low weight, fear of weight gain, distorted views of body weight and shape. Cardiovascular, there may be myocardial atrophy, bradycardia, hypertension, arrhythmia, renal, poor urinary concentration, dehydration, neurological like seizures, cognitive impairment, and dermatological dry skin, lanugo, gynecological amenorrhea, infertility, gastrointestinal gastroparesis, and constipation, hematological cytopenia, and other electrolyte depletion, osteopenia, hypercholesterolemia, and hyperkeratinemia. Electrolyte depletion. So, what electrolyte abnormality will happen in here? Okay. No, okay. And hypercarotenemia. Ca- Hypercarotenemia is just the yellowish skin, looks like the carrot feature. Okay, next. So, okay, we missed this word, like he's craving for foods like salty pretzels, like salt craving. So in evaluation of depression, in the evaluation of the depression, medical causes of depressed mood should always be considered. Medical causes of depressed mood should always be considered. Although these patients' fatigue, anorexia, memory impairment, lack of motivation, loss of libido can be attributed to major depressive disorder. Salt craving, reduced body hair are suggestive of primary adrenal insufficiency, also known as Addison's disease. Primary adrenal insufficiency results from autoimmune destruction of the bilateral adrenal cortex and presence with the following mineralocorticoid deficiency causes renal salt wasting with hypertension, weight loss, hyponatremia, hyperkalemia, and dietary salt craving. Glucocorticoid deficiency leads to fatigue, anorexia, nausea, and many psychiatric manifestations of adrenal insufficiency. It also contributes to hypotension and androgen deficiency. It leads to loss of libido and suppression of secondary sexual characteristics, reduced pubic hair. These effects are typically only seen in women because androgen production still occurs in the testes of men. In patients with suspected adrenal insufficiency, Salt craving and hyperpigmentation are specific for primary adrenal insufficiency and help differentiate it from secondary. The diagnosis of primary adrenal insufficiency made by stimulation with cosyntropin, a synthetic ACTH, low production of cortisol following cosyntropin administration is diagnosis of primary adrenal insufficiency. Okay, is low. TSH is normal. LH is low, testosterone is low. Both are low, isn't it? Is it pituitary tumor? Hmm, pituitary tumor is not only the prolactinoma. There are other pituitary hormones too. Maybe. I'm not sure. Or it may be due to drug. Maybe opioid. It is not Klinefelter. In my when I was in my class 10 SSC exam in Bangladesh, I'm talking about when I don't know any answer, I put a pen in my uh, what can I say, in my forehead and then throw the pen into the page. So there are in there in that exam, this MCQ is very hard. So sometimes I do not pick the MCQ, so I follow that rule. It is not possible now because we are in the laptop. Okay, so male secondary hypogonadism, clinical feature, fatigue, decreased libido, testicular atrophy, low testosterone, low or normal LH. Look at the question, low or normal LH, there is pituitary tumor, but you are right that prolactin will be high. If hyperprolactinemia is present, then it may be the answer. Okay, medications like opioid and glucocorticoid also. Opioid, glucocorticoid cause male secondary hypogonadism, exogenous androgen, withdrawal phase, and infiltrative disease, hemochromatosis, mm, and chronic severe illness, eating disorder, severe weight loss. This patient secondary this patient secondary hypogon sorry in the no, primary is within the gland, secondary is within the pituitary, and tertiary is within the hypothalamus. Okay, this patient's secondary hypogonadism. Look at the cause, like pituitary tumor. Uh, it is not the answer only because the prolactin level is normal. If the prolactin level is high, then it is the scenario fits with the pituitary tumor. If patient is not opioid user and the prolactin is high, then it is pituitary tumor. Got it? And as the prolactin is normal and there is a opioid user history, so looks like secondary hypogonadism due to drugs. Okay, secondary hypogonadism can be differentiated from the primary by I'm reading the explanation. So this patient has secondary hypogonadism presenting with low libido, erectile dysfunction, low serum testosterone level. Secondary pituitary hypothalamic hypogonadism can be differentiated from the primary hypogonadism by a inappropriately low LH. In primary hypogonadism, the elevated gonadotropin LH levels stimulate aromatization of the estrogen precursor androstenedione from the adrenal gland, leading to gynecomastia. In contrast to breast enlargement, in the secondary hypogonadism is less prominent. Secondary hypogonadism is a common adverse effect of the opioid. Opioid suppresses GnRH and LH secretion, mm, leading to reduced Leydig cell testosterone synthesis, decreased spermatogenesis, and testicular atrophy. Additional manifestations can include depression, hot flashes, and osteoporosis. In women, menstrual irregularities are common. Yes, rapid or severe weight loss, anorexia nervosa can cause secondary hypogonadism due to suppression of the GnRH secretion. Mm, although overweight and obese patient may have mildly low testosterone level, moderate weight gain in patients with normal BMI would not cause of symptomatic hypogonadism. Okay, next. Yes, yes. Okay, it's non-classic congenital adrenal hyperplasia. Non-classic because there is no salt wasting. Okay, pathophysiology is autosomal recessive, decreased 21 hydroxylase activity, normal glucocorticoid, normal mineralocorticoid, and increased androgen. Clinical feature early pubic or axillary hair growth, severe acne, hirsutism, and oligomenorrhea in girls, increased growth velocity and bone age, and increased serum hydroxyprogesterone level. Treatment is hydrocortisone. So this patient has non-classic congenital adrenal hyperplasia based on hyperandrogenism and elevated serum hydroxyprogesterone level. The majority of the non-classic congenital adrenal hyperplasia is due to partial deficiency of 21 hydroxylase, which result in impaired conversion of 17 hydroxyprogesterone to 11 deoxycorticosterol, 11 deoxycortisol. Buildup of 17 hydroxyprogesterone is then diverted toward adrenal androgen synthesis, resulting in hyperandrogenism. Girls with non-classic congenital adrenal hyperplasia typically present in adolescence or early adulthood with irregular means, severe acne and hirsutism, virilization, clitoromegaly, depending on the voice, is rare. Since the enzyme deficiency is non-classic congenital adrenal hyperplasia is relatively mild, sufficient glucocorticoid and mineralocorticoid are produced. Therefore, patients do not have the salt wasting seen in classic congenital adrenal hyperplasia, and electrolytes and blood pressure remain normal. Diagnosis is confirmed by exaggerated 17-hydroxyprogesterone response on ACTH stimulation test. Okay. Is it euthyroid 6 syndrome? He has done a CABG. On the fourth postoperative days, it happened. Okay. Okay. Euthyroid 6 syndrome. Hmm. Okay, euthyroid 6 syndrome, low T3 syndrome. Risk factors are severe acute illness, ICU admission, and high glucocorticoid therapy. Pathophysiology is high circulating levels of glucocorticoid and inflammatory cytokines, tumor necrosis factor, interferon alpha, and decreased peripheral conversion of T4 to T3. Diagnostic testing: early low T3, normal TSH and T4. Late is low T3, TSH and T4. Management is observed without treatment, follow-up testing when the patient has returned to the baseline health. Thyroid functions are often an abnormal in patients with severe acute illness. Severe illness is associated with decreased peripheral 5 deiodination of T4 to T3 due to due to caloric deprivation, increased glucocorticoid and inflammatory cytokine release, and inhibitors of 5 monoiodinase free fatty acids. The most common pattern is low total or free T3 level with normal T4 and TSH, often called euthyroid 6 syndrome. However, many experts consider this misnomer and believe it represents with mild transient central hypothyroidism state that serves as an adaptive response to severe illness. If the underlying illness continues, T4 and TSH level may eventually decrease. In general, thyroid function testing in hospitalized patients should be avoided. However, it may be necessary in certain circumstances to rule out hyperthyroidism. To rule out hyperthyroidism in acute atrial fibrillation. When a with thyroid 6 syndrome pattern is found, thyroid hormone supplementation does not improve clinical outcomes and is not indicated. During recovery, patient may experience a modest transient increase in TSH, which may be misinterpreted as subclinical hypothyroidism. Therefore, follow-up testing should be delayed until patient has returned to baseline health. Okay. Yes. D and E. Okay. Overt central hypothyroidism is characterized by low T4 level with low TSH. Low overt central means like in the hypothalamus. So in hypothalamus there is low T4, low TSH along with low TRH. If you do the TRH, thyroid TRH, you will be low. And in subclinical hypothyroidism, characterized by elevated TSH and normal T4 and T3 level. Although subclinical hypothyroidism, there may be low TSH and normal T4 is associated with increased risk of atrial fibrillation. This patient has normal TSH. So how will you remember subclinical hypothyroidism? In subclinical hypothyroidism, like first look at the hypothyroidism. For hypothyroidism to happen, we need TSH. We need TSH to be high or TNSH to be abnormal. Got it? So, so we need TSH. So TSH is elevated, but T4 is normal. That's it. Like what we will do whenever we find a thyroid disorder, we do the TSH first. If there is TSH abnormality, then we do the next. So if TSH is high, then it is hypothyroidism. If TSH is low, then it is hyperthyroidism. And we are adding subclinical because all the criteria is not matched. Like normal, in here both cases there is normal T4. Okay, got it. Next. Yes, yes. Okay. Yes. Yes.
Yeah.
A goucher does not cause hepatosplenomegaly. Is that is gou- Niemann-Pick's cause hepatosplenomegaly? I am not sure. I am very confused. Anemia, there is thrombocytopenia. Anemia,
Okay.
anemia, thrombocytopenia. There is not leukopenia. If that happens, then other things. Uh, is there any 16-year-old boy? I also repeat intermittent pain in the arms and legs. Is it like parvovirus?
No.
Okay. Then it is Gaucher. Yes. Okay, Gaucher causes hepatitis splenomegaly. I was wrong. Gaucher, like there is crumple paper something present and glycogen is glycogen storage disease or lysosomal. This is Lysosomal storage disease, as far I remember. Okay. Okay. Gaucher disease, Gaucher or Gaucher, whatever you say. It is autosomal recessive, prevalence in Ashkenazi Jews. Glucocerebrosidase deficiency, glucocerebrosid accumulation in the macrophage can present in any stage, can present in any age. Visceral organ involvement, splenomegaly, hepatomegaly, bone marrow infiltration. There may be anemia, thrombocytopenia, bone pain, failure to thrive, delayed puberty. Management is enzyme replacement. Management is enzyme replacement. This patient's is most likely Gaucher disease, the most common lysosomal storage disease. In Gaucher disease, glucocerebrosidase deficiency results in accumulation of the glucocerebrosidase in lipid-laden macrophage of different tissue. The range of presenting manifestation can be broad due to varied organ involvement. Bone marrow infiltration results in thrombocytopenia and anemia, which is likely the cause of patient's chronic fatigue, and leukopenia may also be present. Visceral organ involvement leads to splenomegaly, which is typically more prominent than hepatomegaly. Blood cell destruction due to splenic enlargement can contribute to cytopenia. Skeletal involvement can cause bony pain, joint collapse, and delayed puberty, poor growth. Okay, next. Yes, in Fanconi's anemia, inherited bone marrow failure due to defective DNA repair can cause short stature and anemia. In contrast to Gaucher disease, pancytopenia is common. Pancytopenia is common. Decreased leukocyte would be expected. Decreased leukocyte would be expected. Severe splenomegaly is atypical. Moreover, diagnosis is typically in this childhood due to associated congenital malformation, hypoplastic thumbs, and delayed developmental delay. In Fanconi's anemia, like there may be triphalangeal thumb or hypoplastic thumb, and in Fanconi's anemia there is pancytopenia, not like this. And in parvovirus B19, parvovirus infection can cause fatigue, joint pain, cytopenia from transient viral induced bone marrow suppression. Aplastic crisis can occur in patients within uh, with an underlying hemolytic disorder, sickle cell disease. However, these symptoms are typically acute and self-limited, unlike these patients' chronic symptoms. In addition, poor growth and pubertal delay raise concern for a systemic disorder, making parvovirus unlikely. Okay. Diffuse goiter. He does not have Graves. Radioiodine uptake significantly increased and homogeneously distributed throughout the thyroid gland. Is it a toxic goiter or toxic nodular? Looks like. So not, yes. Yes, nodular would be one nodule, yes. We can use drug, isn't it? As he has hyperthyroid, so we can use drug. Yes, homogeneously distributed. That's why it is Graves. In Graves, there is diffuse. Like in hyperthyroidism, there are two or three differential. Like Graves, toxic nodular goiter, toxic multinodular goiter, and you have already to tell me that nodular is like nodular, not homogeneously distributed. Initial case, they have diagnosed early. Proptosis is a late feature, but he has cardiac problem, like he has heart failure with preserved ejection fraction. This cardiac problem is related to thyroid. Okay, this patient's Graves disease, presenting with primary hyperthyroidism, a diffuse goiter, and homogeneously increased radioiodine uptake. Initial management of hyperthyroidism include beta blocker, propanolol atenolol to control hyperadrenergic symptoms, palpitation and tachycardia. The hyperthyroid state in Graves' disease can be corrected with anamide, antithyroid drugs, methimazole, radioiodine uptake, or thyroidectomy. In older children, age more than 65, especially those with cardiac comorbidities, congenital congestive heart failure, as in these patients, antithyroid drugs are favored for initial treatment because radioiodine uptake can transiently worsen hyperthyroid symptoms and may be poorly tolerated. Once the patient returns to the euthyroid state, radioiodine uptake can be considered, or the antithyroid drug may be continued for long-term management. Okay, next. Yes, potassium iodide has transient inhibitory effect on thyroid hormone synthesis and release. It is used mainly in short course, 1 to 2 weeks, in preparation for thyroidectomy and for the treatment of thyroid storm, but is not used when longer term therapy is anticipated. Thienamides, antithyroid drugs are preferred. Choice C, systemic glucocorticoid prednisolone are used in thyroid storm type 2 amiodarone-induced thyrotoxicosis and severe cases of a subacute dequervent thyroiditis. And option D, beta blockers alone are used for painless or silent thyroiditis, which cause self-limited hyperthyroidism due to the release of due to the release of preformed thyroid hormone. However, Graves' disease is characterized by increased thyroid hormone synthesis and antithyroid drug is needed. Next. Yes. Okay. This patient has subacute thyroiditis, presenting with primary hyperthyroidism, elevated free T4, suppressed TSH, low grade fever, and a painful tender goiter. Subacute thyroiditis is thought to be um, Subacute thyroiditis is thought to be due to post-viral inflammatory process and is often preceded by an upper respiratory tract illness. The diagnosis is based primarily on clinical feature, and additional supportive findings include elevated anti-inflammatory marker, ESR, CRP, low radioiodine uptake. Thyrotoxicosis in subacute thyroiditis resolves spontaneously within a few weeks and may be followed by a hypothyroid phase lasting a few months. Most patients eventually recover a euthyroid state, and treatment involves beta blocker to control the thyrotoxic symptom and NSAIDs for pain relief. Glucocorticoids are used for severe thyroid pain for not responding NSAIDs. Okay, okay, we can stop today. Okay, you take your breakfast.